This we're going to focus more on cranial pathology and how to manage patients with cranial pathology on the ward and kind of explaining why you're doing what you're doing. So
yeah, absolutely.
You can use a bit more of your brain power when doing it. So I guess the first thing you get asked with a lot of cranial patients is to prescribe IV fluids. A lot of patients who have cranial pathology don't drink enough themselves and are at high risk of dehydration.
Yeah, either because they're intubated, so on level 3 they're intubated, ventilated. On level 2, a lot of them are step downs for Subarachnoid, and clearly with them we're quite keen on giving them adequate hydration.
Yeah.
And particularly when they first come, or most patients when they come to us are relatively dehydrated, because they've dropped their GCS. They've not, that's the last thing that people think to do, and clearly they can't be given all the water.
So, would there be any particular advice you'd give to someone starting new when they're asked to prescribe IV fluids for a cerebral patient? What would you?
So, as a general rule of thumb, we completely avoid any dextrose whatsoever. Most departments will switch between Hartmann's and IV normal saline.
Yeah.
As a general rule of thumb, we'll top patients up when they first get admitted to make sure they're completely euvolemic, and then try and maintain them with a positive fluid balance if you ignore insensible losses of probably 500 mils a day.
Yeah, so that's why the fluid balance is so important.
The other side of it is clearly, like any other medical specialty, you can get SIADH, so that can put off your sodiums, but particularly for neurosurgery patients who are at risk of having seizures, that can predispose them to having seizures. But there's also other conditions like diabetes insipidus, which can often happen with particularly pituitary patients, but also any head injury patient that includes trauma to the or around the hypothalamus, or laminar terminalis. And then there's a rare condition called cerebral salt wasting, where effectively you pee out salt, and with that goes some fluid as well, and you quickly drop your sodiums. And that needs quite unique management. So the only other thing with IV fluids is if something is odd that's happening, and with pituitary patients particularly, if they're drinking loads, that's probably okay, but there needs to be a threshold which you say, right, I need to check the serum sodium and what's happening here.
Yeah.
The
other thing that we get asked for a lot, obviously, is analgesia, generally for new admissions, but it can be for elective admissions as well. Yeah. Most patients present with a form of pain, and controlling that is very important. I personally, I avoid non-steroidal anti-inflammatories for most patients when they're admitted, particularly if they're pre-op.
Yes, it's not a complete contraindication. No. I think it's important to take that into account, but we tend to go with opiates, codeine, and then I think juniors are a little bit reluctant, and they say, "Oh, but can patients have morphine because they've got a slightly impaired consciousness?" It's more the fact that yes, they can absolutely have morphine or oxycodone or something like that.
It's just got to be considered when you're assessing.
Yeah, you've just got to think, have we actually given too much? Often the neurosurgical nurses are good at not giving them huge doses to start with.
Yeah, exactly. The other thing I think is worth thinking about is things like oxycodone are often better for the kidneys. So, if it's a patient that's more elderly, they'll often advocate using oxycodone as opposed to Oromorph, etc.
Yeah, it's got fewer side effects and it's a bit more expensive. But yeah. So as a side note, opiates can cause confusion, but certainly with any head injury, you need to be careful not to be giving haloperidol that you might normally would on more medical wards. And confusion and agitation is also quite common with bifrontal contusions or with temporal lobe contusions and or epilepsy, so always think that it could be seizures as well. If they need an emergency operation, they'll need a consent form 4, and therefore we should be looking to contact the next of kin. We may end up using deprivation of liberty safeguards and applying for those, so it's important to document the mental capacity assessments, where they're able to understand, retain, weigh up and communicate their decisions, and you must be able to help them communicate that decision as much as possible. So any dysphasias particularly is pertinent. You also got to be wary of if they've got an underlying lesion, i.e. bifrontal contusion or hematoma or tumour, that can invoke a slow progression of behavioural change and actually change their decision making process, and they may not be able to be more rational and demonstrate adequate rationale to weigh up a decision, and often it's best to get consultant input at that point if there's any underlying lesions that may cause confusion where patients are wanting to self-discharge.
I thought, so as a pathology, a good place to start would be cerebral tumours.
Yes, the most common condition that probably presents to us from a cranial side, but also presents, and patients are often kept in peripheral hospitals, and we've got to try and get them worked up for surgery. And not all of them need surgery, not all of them are fit enough for surgery, and making those decisions can be difficult.
So how do people with cerebral tumours usually present?
So generally they have a seizure or have some form of focal neurology. They may even get seen by stroke and thought to have a stroke, and they've actually had either a haemorrhage into their tumour, or occasionally some of the brain swelling around the tumour has suddenly gone into an eloquent area of the brain, and they have a focal deficit. Most will have a progressive headache that never goes away, but that's not really that specific to tumours at all. It's the most common, most common complaint that everyone has is everyone will have a headache at some time in a year of their lifetime.
So a lot of these patients with cerebral tumours get started on steroids. What would kind of guide that?
Yeah, so not all of them will. So the scan results will often make us consider steroids. The only thing that puts us off steroids is if they've got a clear underlying abscess. And sometimes the two can't be differentiated, so we might be a little bit hesitant when making that decision. Right. But clearly, steroids can reduce the swelling around the tumour. If there's none on the scan, there's not really much point starting it because they've got severe side effects, and they can cause lots of long-term complications. But we tend to go 8 milligrams twice a day, and don't remember this. Do remember the second dose is at 2 o'clock in the afternoon, not at 8 o'clock at night or 10 o'clock at night. Otherwise, they're more likely to be up all night. And the other thing with dexamethasone, it's got a half-life of about 52 hours. So, it's there for about 3 days, and still weaning off after that, even after a single dose. The other side of it is, particularly with head tumours, not to just a knee-jerk reaction into giving steroids, is if there's appearances like a lymphoma, you'll make it shrink, and we won't be able to get a diagnostic, or highly unlikely to get a diagnostic sample, and it'll be full of ghost cells, and we'll have to wait for it to regrow and then biopsy it again with an appropriate timing, and that can be difficult. And
for fear of labouring the point, I guess our usual disclaimer with steroids, making sure patients have got a plan for when it's going to stop or when it's going to be reviewed, making sure they're on PPI, and making sure you monitor their BMs, because it may...
So the thing that's most commonly forgotten, I guess, amongst the juniors is BMs need to be monitored.
Yeah.
That will often be remembered by the nursing staff. And don't forget that if it's a high-grade tumour, we're unlikely to stop it. So if it's a grade 3 or 4, often they'll be discharged on a low dose and they will not stop the steroid. If it's a complete excision of a low-grade tumour or a benign tumour, then we may stop them before they go home. And don't forget bone protection for the the patients that need the long-term Dex.
Yeah.
So that can be in the form of Adcal or bisphosphonates, etc.
Yeah. So another acute admission that you get with cerebral is subarachnoid hemorrhage. There's a few quite close parameters that we want to look at here, isn't there?
So the management vastly changes according to when the aneurysm, if there is only one aneurysm, when that's secured. Yeah. So at the initial presentation, often they can have a good GCS of 15 and just have a really severe headache. The other side of it is that they need to be intubated and ventilated and brought across to the neurosurgery centre. The key first process is to make sure the blood pressure is well controlled. We're not pushing the pressures so high that it's unlikely to burst and rebleed. Yeah. We need the head of the bed up to at least 30 degrees, maybe even 40. Their medication is well controlled, they've got good analgesics, they're not having nausea, vomiting, straining to go to the toilet because they're constipated, so they need antiemetics, laxatives, and all their regular antihypertensives, and they ideally need that calm environment for them to not get stressed out in. And so preventing a rebleed is your first thought when patients come in through the door, and then getting them into, if they haven't had a CTA, and then often it goes into a DSA with interventional radiology, providing a stent or a flow diverter or web device. And then once it's secured, and if there are no other aneurysms, then we start to really ramp up the pressure. And depending on the clinical status, that will be guided by the consultants of what pressures they want. But then we'll drive the pressure to avoid vasospasm or delayed cerebral deficits, which is the new term for it.
I suppose the other thing that we often start with these patients is we start IV fluids and nimodipine.
Yeah, so IV fluids is key. So again, top them up with saline or Hartmann's up. At least probably give them 3 litres over the first day. We've moved away from Triple H therapy, so we tend to aim for not hemodiluting them, because we basically overload patients, and particularly as you age, you get more aneurysms. So actually, there's a large proportion of patients that are quite elderly, and we end up just fluid overloading them and causing more problems. Yeah. So I think the key thing is to make sure they're well filled, particularly in the first day, and then after that,
being guided by the fluid chart.
Be guided by that.
So you're looking for positive 500 mils because that accounts for the insensible losses, and that's keeping you bulimic.
Yeah, that's after the first day, I would say. Yeah. And then nimodipine is key, but it's not as key as sorting out the blood pressure. No. So your blood pressure is the main priority. Nimodipine, yes, it's going to reduce, or it's been shown to reduce vasospasm, and that is really in day 3 to 10, or between 4 and 7, is the main risk of that happening. So really, that's often not when the patient's presenting to the neurosurgery department.
And they would usually just continue that for 21 days from when it started, unless it's stopped early because it's proven that there isn't an
Yeah, so occasionally we'll do some double checks that even though that CTA is negative, we'll still bring them across because it still looks like an aneurysmal bleed, and clearly they'll have the same symptoms, but often we'll have a good GCS of mostly 15, and it will be in and around the some of the basal cystins or mesencephalic cystins, and they'll just do a DSA to double check, and then we can stop it, and that's that.
So if I summarise what you've said, really, if you want to write, if anyone wants to write this down, it's like a checklist for a subarachnoid hemorrhage patient. Generally, you're balancing the risk of rebleed against the risk of vasospasm, and the way you're doing that is you're making sure the patient is nursed in a calm environment with the head up to 30 degrees. You're prescribing them good analgesia. You're prescribing them laxatives. You are prescribing them nimodipine and IV fluids. You're monitoring their blood pressure and making sure that you manage that closely.
Bringing that down, before the aneurysm is secured, and then afterwards you want to let them drive themselves. So often we'll then head on in a completely opposite direction after it's secured. Yeah. And
then you're doing obviously your admission bloods, which would include urine electrolytes, but you want to make sure that you're doing that daily as well. To monitor sodium in particular.
Yeah, so subarachs are at increased risk of getting sodium electrolyte abnormalities, and so it's key that we keep an eye on that.
Yeah, and then finally you're considering whether nimodipine is appropriate with your registrar, and you're going to make sure you do a VTE prophylaxis, VTE assessment, which obviously if they've had an intracranial bleed, they're unlikely to fit for low molecular heparin.
So they won't until, and then afterwards, after they've had the securing of the aneurysm, then they often will. Not always.
But obviously we don't want to forget any mechanical DVT.
Yes, true. Absolutely. Yeah.
So so that's the main things there. Now, when you get a subarachnoid hemorrhage, it can cause hydrocephalus.
Yes. Because it's blood in that fluid that is stopping it getting absorbed.
And it's those patients that may need an EVD.
Yeah, and if they've got an electrolyte abnormality, that can cause confusion and their consciousness levels to slightly drop. And it can be a little bit confusing as to whether it's an electrolyte cause or whether it's a development of hydrocephalus.
So I think it just highlights the importance of when you admit a patient, really doing a very prescriptive GCS. Is the patient orientated? Do they know where they are and what their time, age, date of birth is? Because even just a few drops in GCS is important.
Just their level of drowsiness. So they could be technically GCS 15, but they'll literally go to they'll just nod off within about 10 seconds or 30 seconds. That's very drowsy.
So it's really important to write that down.
Yeah, and people with subarachs can have hydrocephalus, so they might need to go down to straight down to theatre. And for poor grades, they might already be sent straight from the peripheral hospital into theatres for an EVD occasionally.
So
the other thing with subarachnoid patients is just to be aware if they're having ongoing vasospasm and there's concerns regarding this, they can go back to the interventional lab and have intra-arterial nimodipine. The other side of it is patients often graded when they first come in. The most common grade is the WFNS, and this basically predicts the patient outcome, how well they do afterwards, and one being a good outcome, a good grade, whereas grade 5 is a very poor grade subarach. The main determinant is their GCS, and then there's some differences between WFNS grade 2 and 3, which is basically whether they've got any deficits or not. And then there's also a Fisher grade, which is the degree of haemorrhage on the CT and where it's located, and that predicts again the risk of vasospasm, which is mainly grouped between 2 and then 3 and 4 is a significant increase of vasospasm. The other differentials also to be considered in any subarach is it may not always be due to an underlying aneurysm. That's the emergency that is why they're under neurosurgery. But there are other things, so traumatic, and occasionally you'll get blood in the basal cisterns, but also spontaneously you can get a venous perimesencephalic bleed. It can be from AVMs, AV fistulas, moyamoya disease, tumours, which is why sometimes MRI heads and cervical spine scans get ordered for those. You can have venous sinus thrombi and cortical vein thrombus managed by neurologists. Again, vasculitis causing multifocal subarachnoid hemorrhages. You can get reversible vasoconstriction syndrome and PRES, which can give you particularly distal subarach, and then there's also amyloid occasionally. So seizures are common in neurosurgery, and mainly the nursing staff already have most of the basics already sorted, so they'll have soft surroundings, they'll have pillows over some of the bed rails to prevent patients from hitting their arms on them, for example, or legs. Typical management, ABC as any emergency. Always remember some benzodiazepines. They'll have plenty on the wards. It depends whether you've got IV access. If you do, can give small doses of diazepam, and I tend to start small and give it regular, so you don't knock them flat for ages. You can also give it rectally or buccally, and then the other common medication given is Keppra. Patients may be on Keppra already, but if not, they'll be given a 1 gram loading dose, and it's quite common for you to see nursing staff already prepping some Keppra, because if you think they're at high risk of having seizures, if the patient's already having a seizure now, you don't want another one in 10, 15, 30 minutes time, and that could be due to the underlying lesion they have. The other side of that is if they're already on Keppra, they may also, I think at that stage definitely start, in any scenarios you should involve the registrar, but the next step really is looking at whether they're for phenytoin or anaesthetic support at that stage, and to induce them into a coma to prevent the seizures. And phenytoin is again, it's needs to be a slow infusion because of the alkaline base to dissolve the phenytoin in, and it's roughly, for a normal weight human being or adult, it's about 1 gram you give, but again it's got to be guided by their weight, and just be careful with trying to reverse. If you think you've given too much benzodiazepine, don't jump onto flumazenil straight away, because that can lead you back to seizures, and because it's a competitive GABA antagonist, you're then fighting different medications you're giving, so definitely don't give that without a senior reg or consultant advice on that one. The other side is, whilst we're on antiepileptics and phenytoin, basically they're complicated, so if any doubt, ask your pharmacist is the main rule of thumb. Phenytoin, it's obviously not linear response or absorption. We often use drug levels to monitor their response and their absorption. Typical starting doses are, if they're IV, you split it 3 times a day because they're highly alkaline, and if they extravasate, you get quite harsh tissue necrosis around that. And the alternative is you can just have it once a day with 300 milligrams orally or NG. Just be careful with some of the syrups, and it is dependent upon the makes, because they convert into different dosage amounts, or the actual milligram that you give will convert into a slightly different absorption of it depending on the base that it's dissolved in, particularly in syrups. They bind to proteins, so take them on an empty stomach, and if it's often given at 5 a.m. if they're on an NG feed, because that would be when they're having their gut rest. Some patients, though, they push them onto a late night dose because they think there's some sedating effect from the phenytoin. So that's the other way of managing, but it depends when the NG feeds start and finish. Keppra IV equals all dose. They're all the same really. IV is just you avoid any complications with vomiting and not being able to keep it down. Prophylactic dose is 7 days. Again, if they've had seizures, the most common thing is to just follow them up in clinic with regards to looking towards stopping it. Change in mood is quite common side effect in about 20% of people. And then any other antiepileptics, it's really important when you're prescribing it to note down the different makes or the brand that they are using, whether it's modified release, slow release, even if it's capsules or coated tablets, because you can't always put them down NGs because you ruin that lining, and sometimes there's no other option really, and that's when you get the pharmacist involved in helping you work out what's the best alternative or the kind of conversion from one to another. And then carbamazepine, just to note that often that gives you a chronically low sodium.
They may have a VP, a drain put in, a VP shunt. No, not a VP shunt, sorry.
An EVD.
An EVD.
Yeah.
But I think we've got that later on, haven't we?
We have, I think, yeah.
So shunts, it's a common reason why people come in to hospital, isn't it?
To neurosurgery, yes. It's because the symptoms can be sometimes quite difficult to tease out, whether it's actually to do with the shunt or whether they're migraine, headaches, etc. So you can inspect a shunt, you can see how the reservoir fills if it has one. Often we would not advise anyone else but neurosurgery tap them, because you can put a needle straight into them and test the fluid and whether it's being able to aspirate from it or not. Yeah. You've also got to know which systems have the valves and anti-siphon devices in which places, because you might be sucking backwards up from the shunt rather than from the brain out. Yeah. And I think that's it. I mean, it is different in different populations. So particularly in peds, they're much more common to overdrain, and you can have over-shunting problems. But I guess the most common problem presenting to neurosurgery for referral is it a block shunt?
Yeah.
Yeah. Is
it a block shunt? Yeah, or is it under shunting?
And the key thing, the two main investigations at the very start are get a shunt series, get a CT head as the bare minimum, and also you'll get used to doing fundoscopy in neurosurgery, because it's key to look for papilledema. But again, you might not have that feature in an acutely block shunt.
Yeah. Pituitary patients that are coming in for pituitary surgery.
So they're always unique, aren't they?
Yeah.
And you can have pituitary apoplexy patients that acutely present. But it's important to have a look at the ophthalmology examinations before, so both fundoscopy, visual eye fields, and whether they've got any ophthalmoplegia. Yeah. And also they should have a full workup before. So most, the pituitary screen is prolactin growth hormone, IGF-1 testosterone if they're male, FSH, LH, TSH, and then the free T4 and 3. They need a full set of the all the thyroid ones, not just TSH, for pituitary patients particularly. Yeah.
And you'd work closely with the endocrinology team here. Usually you'd have endocrinology advice.
So if it's an elective patient, they've already been worked up.
And for these patients, you'd usually give them steroids, wouldn't you, before surgery?
They'll often have it at induction,
and
then they'll have some regime afterwards. So I guess the apoplexy dose is 100 milligrams IV 4 times a day. And some places will go on to that and then drop down quite quickly after that. And they'll often do some tests of cortisol, particularly morning cortisol, because that's the key one, to then determine what actual dose patients need of hydrocortisone.
And I guess the other thing we monitor closely with them is their serum and urine sodium and osmolality.
Yeah, so the osmolality always helps you determine what's happening with their fluid status,
Yeah.
and it feeds into kind of making that judgment. And I think it's important that post-operatively, my rule of thumb is if they've produced more than a litre in 4 hours of urine, then they need a check of their what we call a paired sample, so urine sodium and osmols and serum sodium and osmols. Yeah.
And obviously they've all got a catheter in from surgery, and you'll be using that to closely monitor their fluid status.
Yes. Yeah.
So 1 litre in 4 hours.
Yeah, or just think of it 250 miles an hour for more than a few hours. Then if they start thinking, so we've got to make sure that their sodium levels aren't going to suddenly go awry.
And obviously we usually approach this through the nose. Transphenoidal. So a lot of I've been called a number of times to patients that have had a nasal CSF leak following surgery. How would you go about managing that?
So one, determine whether it is a nasal CSF leak, and often they'll have some kind of nasal dressing over the top, and you can see the haloing effect on if it is a CSF leak. Don't forget that it doesn't always have to come out the nose, and it can actually go down the back of their throat. So if they're getting a salty taste at the back of their throat and a dripping sensation, it doesn't always have to be constantly dripping, but a couple of times in a day, then that's when you start getting worried that there might be a leak there.
How do you manage that?
Well, there's a variety of techniques. Some people will take patients straight back to theatre, so it's important to tell your bosses that it has happened. So patients may need to be kept nil by mouth and then taken into the emergency theatre. Some people will put in lumbar drains, managed slightly differently across different units. And also it depends on the case and how easy the nasal flaps, etc. are to put up and create.
So after the acute, the immediate post-operative period, patients generally, when they're ready for discharge, you need to be thinking about making sure they've got endocrinology follow-up, as well as often they have neurosurgical follow-up as well.
So it's important, one, that they've got access to advice that they need to, if they become unwell, they need to do a double dosing of their steroids at least. So sick day rules, they often call them.
So in the TTO, you need to provide an emergency hydrocortisone pack.
Yes. And then in addition to that, they need close endocrine follow-up. Even after discharge, it's common for them to, in the next couple of days, have a repeat blood test as an outpatient with the endocrinology specialist nurses to just recheck that just in case.
Okay, so another very common presentation to our department is obviously following head injury. They may have had, any number of intracranial bleeding in different locations. General measures that we use to manage these, I would say. How would you kind of
any head injury? Well, it's based off this, so all of them will have a CT scan, and you need to try and reduce the ICP as much as possible, get their pain under control. Again, it depends whether they're sedated and ventilated or awake, and there'll be a variety of patients that have those. But it's key that we're making sure that their platelets and their coag functions normal, and that's corrected in particularly head injuries. Some people will start some seizure prophylaxis depending on the location if they have contusions, or if there's any evidence that they had some seizures at the time, then we'll definitely start that.
One of the common things I think you get called for as an SHO on the ward is someone who's had a head injury who's deteriorated while they're on the ward. What would be the differential that you'd be thinking if you're in your head when you're first called to see a patient who's deteriorated following a head injury?
So I guess blossoming of contusions, they could have further bleeding. If they've got an extradural, that could have well got bigger. Or sometimes with an acute subdural, they might just have more swelling from their brain, and then that's just causing midline effect, a little bit more herniation.
Right.
And don't forget the herniation syndromes, really. They could easily be having a seizure. There's often a debate on ICU as to whether the patient's having a subclinical seizure or whether we can see it, so often an EEG or CMAP's ordered to look at that in a little bit more detail. Whether they've got any sepsis going on, so if they've had a skull fracture, particularly one that's open, then they're high risk of getting meningitis. So often all skull fractures will have the vaccines before they get admitted. Don't also forget the systemic ones, so if they've got electrolyte abnormalities, if they've got chest infection, urine infection, all the standard medical differentials for anyone deteriorating, that could have happened to them too. And you can get some head injury patients or anyone that's had a significant brain injury from Subarachnoid. They actually have T-wave changes and some other things, so you can occasionally get changes on the ECG from that, and significant cardiac events.
So you mentioned the vaccinations. When do we give those?
Normally as soon as possible. Ideally they're given in A&E.
And what sort of patients would get them?
So any skull-based fracture, and particularly if there's any intracranial pneumocephalus, so air inside the head, then we would look to give those to prevent them, or at least protect them.
Here we have a standard list of what we give. I guess it might be different in different trusts.
No, it's pretty uniform. So he'd be Meningovax and Pneumovax as well.
Yeah, so it's 3
to
vaccines.
cover for pneumococcus. Yeah.
Okay, so another patient that you often get called for in the wards who's deteriorated is a patient following surgery. So if someone's deteriorated following a craniotomy, what would be your craniotomy? What would be your differential for that as opposed to with a head injury?
So in the acute scenario, you're worried about an extradural, and most, I guess, juniors think of extradurals as happening with trauma, but equally that can happen with craniotomies.
Oh, right.
So particularly in recovery, if someone's got better post-op and then is starting to dip afterwards, that's when to start thinking, is something not happening here? Pay close attention to the pupils. That will always give you an idea of what's happening. And to be fair, when we finish procedures, often we'll have a quick look at the pupils and check them. And that's a common kind of habit really of us. They can get edema and swelling, and especially after lots of retraction on the brain, if they have had some, that's very common. Dexamethasone may help, but it doesn't always get rid of all of it, particularly if you have a look at the scans. Seizures, again, probably not so much of a problem these days as it used to be, and is much more common in traumatic head injuries.
Just to go back to traumatic head injuries, would you routinely prescribe antiepileptic now?
No, not commonly. So I think if there's contusions in the temporal hemispheres, temporal lobes, then I would. Yeah.
Or maybe if they've already had a seizure.
Or if they've had one, definitely. Yeah.
So then you would start.
And then if there was a query that they were, and the scan results don't always match up with what the patient's doing, you may just see if they are. It depends what your access is to EEGs and CMAPs.
Right. Obviously, a lot of what we do instruments under the dura, or patients who even present with an injury that's exposed at. And then wounds leak. It's one of the most common things we get called to as an SHO, a leaking wound. How would you approach a CSF leak?
Well, I think the key to remember is that neurosurgery, someone, when I first joined and started looking at a consultant closing an operation, he was saying, oh, well, this is underwater surgery, because that's what you're trying to do. You're trying to get rid of as much air as possible so the seizure risk is lower. Yeah. And you forget that the brain, because you've opened up the brain and you've seen it pulsating away, you forget that you actually, everything's underwater when it closes. Absolutely, effectively. Yeah. So if there's any small pathway for CSF to leak through, it will leak. So I think it's really important that wounds are looked at on a daily basis from the medical team and on the nursing team, that they're closely monitored.
And having a low threshold for putting a stitch.
Absolutely. It needs to be clean. It needs to be done cleanly on the ward, and be slightly careful with using any local anaesthetics, because that may actually go into the brain, and then it can cause more issues with that. But certainly the best way to deal with CSF leaks are promptly deal with it and properly secure it. So the main thing is put stitches in it and seal it up. Yeah. Don't wait. Don't think, oh well, that may stop. Just monitor it. That's not a thing to do. No. Don't monitor CSF leaks.
That's exactly the key thing, I think, compared to other specialties. We intervene early, because also you've got a risk of, if the CSF is leaking out, there's a risk of pathogens getting in. Yeah. So it means you've got an open tract.
Yeah, and if you get an infection intracranially, that's for either cancer patients, can stop them getting their chemotherapy, and has a significant impact on patients. If that becomes a ventriculitis, they can drop their IQ points by over 10. So
each time they get an infection. Exactly. We wouldn't routinely prescribe antibiotics if they had a CSF leak, would you? If you got there quickly.
Most people wouldn't. No.
But it's obviously worth mentioning to your senior.
Again, yes, that's where you want a senior decision, because some cases are incredibly difficult. It may have been a long operation with a high infection risk, and they want extra protection. And going with infection, you can get infarcts from infection and meningitis. You can get widespread infarction and really poor outcomes. So.
In terms of inserting a lumbar drain, that would always be a consultant decision, wouldn't it, to manage a CSF leak?
Yes, so I think especially for a pituitary, definitely yes, because occasionally if you're draining fluid out the back, quite literally, you can be sucking air in. Yeah. So you've got to be careful that you don't just suck air in, and actually by sucking air in, you're sucking in pathogens. Yeah. So I think particularly for pituitaries, that's definitely a consultant. I would always involve them, whether and really that's a registrar that's making that decision.
Exactly. It's just on the ward. I have had someone ask me before, in the middle of the night, would you want to put a drain in at this point? So I just think it's just worth flagging up to anyone starting new that don't go making that decision.
Yeah, don't be putting in lumbar drains and don't be doing LPs without someone saying, absolutely. Yeah, that's fine.
Yeah, absolutely. Okay, now sodium, we so closely monitor sodium here on neurosurgery, don't we? And it's something that even the consultants are asking for daily updates on what the sodium is on the round. As we've already said with subarachnoid haemorrhage, they need daily sodiums. So I guess you need really, to start neurosurgery, one thing that's worth looking up is how you're managing a low sodium, how you're investigating it, and then based on those osmolalities and those paired samples, what you're going to do to sort it out. But there are some unusual things about neurosurgery, isn't there? Some patients can't have fluids. They can't have fluid restriction.
Yeah, so the subarach patients, for example, you definitely wouldn't want to make fluid restrict them. Yeah. So if they have slightly low sodium levels, the first way that we typically would manage that is actually increasing their salt intake for that period, and either giving them salt tablets, or occasionally, if it's only mildly low, then we might just ask them to particularly put more salt in their soups, try and hide it in their food. Well, we wouldn't hide it in their food, but the easiest thing is to put it in soup, because that's the easiest thing to hide it in, or salty crisps, etc.
But there is the options to prescribe slow sodium tablets or sodium via the NG tube, and there is in the very rare cases you may use the option of
hypertonic saline, either 1.8 or 2.7%.
But that would obviously be done with more senior advice, and
that's generally with cerebral salt wasting syndrome. So where you're effectively peeing out loads of concentrated urine with salt, you'll want to replace that and make sure then they're not getting dehydrated, and their salt levels aren't dropping. So
But I guess I think one of the tripping blocks for a starting junior would be that they got a subarachnoid patient who's got a bit of a low sodium.
Don't suddenly fluid restrict them.
Exactly, they follow the standard finally a medical school pathway, work out the patient is slightly hypervolemic, put them on fluid restriction overnight, and suddenly in the morning
they've had a stroke.
So it's very important to be aware of that subtle difference. Okay, and then GCS, I think, is one of the things we assess most commonly. Assess it to every patient we see when we first come in.
I think the main thing that, or my main points here, is that people use numbers, and numbers were great for a research tool for giving you an overall score, but in actual fact, that's not what you want. Even people that are used to the GCS system and use it many times a day, it's always better to communicate it with what someone is doing. Yeah,
because getting one number wrong here or there may be the difference between intervention or not.
There's always going to be human error, and communicating that happens on both ways. So when whoever's seeing the patient interprets it and then converts that into a number, the person that's receiving that number has then got to convert that into the actually reality of what's happening. And why waste that double conversion when actually you can communicate on what's happening to the patient on the ground level?
So I suppose the one of the most difficult things about Glasgow Coma score is that differentiation between your abnormal flexion and your normal flexion, that right in the middle of the motor score point. How would you give any advice to someone who was assessing that?
So there's 5 main key things really. With abnormal flexion, it's slower. It tends to go across the body. You get pronation of your forearm and your wrist, so you go into more of a decorticate position. Your thumb tends to be clenched within your hand, and it's not uncommon that your legs extend. But don't forget, this is the best score. So often your arms will be doing the main reaction, and your legs may they may be ignored because you wanted to get them. Don't forget, for every part of the GCS score, it's what they're doing best.
Yeah, exactly. So if the arms are flexing and the legs are extending, then you take the flexion.
You take the flexion, and sometimes the arm will adduct, whereas flexion goes out to the side.
Yeah, and equally, you don't want to assess a limb that is that has focal neurology. You want to be assessing it's an assessment of their GCS, so you don't want to assess.
I think it's where the reflex is, isn't it? So it's whether it's above the red nucleus, out of and it's happening above the brainstem and everything's intact, or is it below the brainstem and there's something vital that's pressing on the brainstem.
Yeah, definitely.
So there's a couple of difficult patients that we don't know what to do with, or some patients don't know how to score. So if they're intubated, we just put T by it. If they've got various scenarios, so they've got facial injuries, eye swelling, or the eyelid tape is closed, then we can't really do anything about that, and we just ignore either that eye, or occasionally we'll try and open the eyelids if we can, if it's safe to do so.
Yeah.
And occasionally the important thing is with dysphasic patients, you've got to try and basically help them achieve their highest ability. So they could be dysphasic, and they might have a low verbal score, but actually can get them much higher, and they might not be confused at all. They might be completely orientated, but they just can't tell you what they're trying to communicate.
Right, yeah. So it's not a very good assessment of...
Yeah, so for receptive, you've got to use visual actions, and saying it at the same time. And then for expressive dysphagia, you might give them multiple options. And often if they can repeat words, that might just help them overcome, and they might be able to choose one of those options, and that gives you a better idea of what's happening. The only other common things I would say with GCS is nail bed pressure, and with peripheral withdrawal. We've gone away from that really these days, and particularly people can get nail bed hematomas and lose their nails completely for life, because it's repeated. If you do hourly obs for a month on end, that's a huge amount of trauma happening to those nail beds.
So we tend to do trapezius pins for suborbital pressure, don't we?
Yeah, or just in front of the mastoids. That's my favourite, I guess. The other thing to be wary of is a grasp reflex. So if you're saying to squeeze your hand, just be slightly aware that for some patients that'd just be a pure reflex rather than an actual reaction. If there's a query whether it is a reflex or not, you've got to ask them to let go, and they've got to successfly let go in a reasonable time period.
Or you could ask them to stick out their tongue, or
some central
they're slightly
thing.
better, aren't
they?
The only I think the only other thing with GCS is it's making sure you've written it out in your words, not your numbers, like we said, and making sure that you've got as accurate as you can. That's the main things.
Yeah.
So once you've done GCS, one of the most common things you get called for on the ward is a drop in GCS, because they obviously done on every set of observations, and knowing kind of like a differential for what could have caused that is important, but I guess it's very dependent on the pathology they've got. Yeah,
so some patients will naturally fluctuate, and you'll notice overnight some of them may drop a little bit, particularly if they're behavioural. They'll not want to interact with medical staff members, so they'll try not to. I guess the change with that is once you go to then testing it with pain, then they start to wake up and then start to change. And often a change of person asking them the same questions will invoke a change. Not all the time though. And again, I think these are similar differentials to the head injuries, so seizure, electrolyte disturbances. Occasionally, don't forget about the sedatives and the infusions if you're on ICU or HDU, sepsis. The main things that we are worried about, and you've got to think in your head, is this a bleed, is this contusions or hydrocephalus that we can deal with surgically. So that's where you'd order a CT head to rule out those.
So on neurosurgery, we monitor people's intracranial pressure quite closely, and we, how would we normally monitor their intracranial pressure?
So the only realistic way of doing that reliably is inserting a wire, mainly through a bolt screwed into the head, and then the wire goes out and then is transduced and connected up to the normal monitoring sets at the side of the bed.
And definitely that's a procedure that you can get involved in quite early on as an SHO, and something that you can do independently after a few goes through with the registrar. So particularly, of course, and it's a logbookable procedure, so definitely want to be involved in as a junior on the ward. And I think it's the last procedure where we actually hand drill into the head. So
unless you're doing COVID and you're trying to avoid
true.
any aerosol generating procedures.
Causes of raised GCS. So a normal ICP is about, what would you say normal intracranial pressure would be?
Varies between individuals really, and we don't really know what normal ICPs are, because normally that's investigated for people that have headaches. But we think it's anything below 15. It should for adults definitely be above 5.
Yeah.
For paediatric cases, 0 can quite be the normal. So between 0 and 10 for peds and adults, a bit higher. Yeah.
And what would cause you to raise your ICP?
So any straining, as we were saying before, with like subarachs, coughs, physios, ventilatory pressures. If they're lying flat for a scan. So the difficulty is when you decide to take someone for a scan, there is a small risk there that you're lying them, that it's difficult to keep. You can't lie them or keep their head up on a CT scan, so they've got to lie flat for that.
Yeah.
If they're waking up from sedation, they'll often have some high pressures come through as they're often waking up, and in centres that they're not used to that happening, then they might start to worry that actually, the ICP is going up, we need to put them back to sleep.
Yeah.
PCO2 can be high, and that can high PCO2s can vasodilate the vessels that inside the head takes up more space, increases your ICP. And then you've got all the other things there that are surgical, so bleed, hydrocephalus, contusions, blossoming, or sometimes swelling like an evolving stroke.
If someone is getting a raised ICP, we often get called to that overnight as SHOs. What would be kind of our thoughts?
So there's 3 stages to it really. There's the bare basics: head of the bed to 45 degrees, head in a neutral position, so your veins are draining away from your head correctly and well. You don't have any intubation ties that are going around the front, and they're using adhesive ties to keep the ET tube in. And then the other thing is to avoid hard collars. So if they're entirely ventilated, sedated, they don't need a collar on all the time, and that will increase their ICP considerably. So the best thing is to have it off and at the side of the bed, maybe even next to their neck, so you know that they need a hard cervical collar if they're to be turned, etc.
Yeah.
So that isn't forgotten. The bare basics: normothermia and preventing seizures. The next side of it is hyperventilating, carbon dioxide levels, bringing that down, and hyperventilate them, trying to keep lower peeps and shallower breaths.
Right.
And then the other side is more of the anaesthetic side, so sedation with a variety of medications, paralysis. Hypertonic saline or mannitol can be given, but really this should be kept for emergencies, for buying some time to then get them into a scan or into theatre to then perform a decompression. And then occasionally, again, a consultant decision to give thiopentone, because that's got very significant side effects, and you can't monitor people's pupillary reflexes with that when you're starting to give that, so it can be, and they can blow and dilate out their pupils.
So generally what I'll be doing is I'd go down, I'd do my least restrictive measures like you spoke about, raising the head, making sure there's nothing restricting the hands, and then I'd check the obs and check with the nurse whether they have any seizures, and then I'd probably discuss with one of you guys. I think that would be entirely reasonable, and then closely involve the anaesthetic team, because they're much more used to ventilator settings. Yes, exactly. Yeah. So, if someone has got a raised ICP that you can't manage like that, for example, someone with a subarachnoid haemorrhage that's had hydrocephalus, they may need a drain put in. So we've spoken about a ventricular drain.
Or you can put in a lumbar drain as well.
Yeah.
Again, a surgical procedure generally carried out on the ward, but again must be sterile.
Yeah.
And the lumbar drains are more difficult to manage because they are slow. They're smaller tubes, they're slow flowing, and they're probably more likely to get infected because of their placement. But then the other side of it is if they need to reduce that ICP, the last thing is surgery and the best surgery is done relatively early. So making that decision in a timely fashion needs to happen. So again, consultant involvement is key, and it's okay if you escalate that up. Yeah,
and again, I think that inserting an EVD or a lumbar drain, they're all very good procedures for a trainee. So trying to get to theatre overnight, put the EVDs in with the reg, or put the lumbar drains in, is invaluable experience, I'd say.
Absolutely.
But I think managing EVDs is something you've got to get to the bedside, and you've got to learn how to get a registrar to show you how to take a sample, how you're measuring it, how you're levelling it, and how you're interpreting the output, because you'll get called time and time again. Is an EVD blocked? Does it need to be moved, etc., etc.
Yeah, so, and if it needs to be flushed, again, that needs at least a reg level decision as to what to do about it.
Exactly. EVDs. When you're first starting neurosurgery, I would expect you just to talk to the registrar before intervening with anything to do with the EVD.
Yeah, absolutely.
Perfect.
Thanks.
That's good.